As important as the resection itself, I think is the assessment of the defect afterwards to make sure that you don't have delayed complications. And so that's why this session will be dedicated to the question, what should I do after resection and how should I manage any complications?
So first question, can we predict post-EMR bleeding? Well, first of all, the definition of significant post-EMR bleeding is bleeding which requires presentation in the emergency department, hospitalization or re-intervention, and occurs in about 6% of cases after large EMR. There are some risk factors. Increasing lesion size is one of them, right colonic location, as per news, intraprocedural bleeding requiring endoscopic control, use of non-microprocessor controlled current, older age, and ASA grade 3 or 4. These tables show, these large multi-center studies showed the development of risk factors for clinically significant post-EMR bleeding. They are useful to stratify the risk, but they cannot prevent it. So we can use them and react accordingly, but still, these are scores and not prevention measures. We actually published a study with Michael Burke and David of the defect itself, and we did find that 3 or more visible vessels within the PED may be predictive for significant bleeding and may define a target group for real-time prophylactic intervention. Now, as with ulcers, as Christophe nicely demonstrated in his lecture this morning, we target vessels, so we want to think, is this something we can do? Then there was this study from Amir Klein on computer-assisted morphometry, and they say the morphological appearance of the blood vessels within the post-EMR defect may have a significant role in predicting delayed bleeding, and it will allow for a more detailed and accurate quantification of blood vessel morphology and can be used as an assistance tool, basically. Now, prevent it. There is where we all aren't too sure if there's really something published in the past that actually proves we can prevent it. So it happens because we all know that a post-EMR defect contains numerous blood vessels of various sizes, and they are thought to be the bleeding source. They therefore appear to be the logical target to prevent bleeding. It is also the most frequent complication after EMR, so we really want to do something about it. However, previous studies, and this study is mentioned before, prophylactic coagulation to prevent bleeding does not show a significant difference in occurrence of bleeding. And as John said during a talk yesterday, don't you even cause more damage to the submucosa by actually coagulating these vessels? Also, APC does not decrease it, and clipping, as Rav also already said today, the studies are sometimes a little bit conflicting. Can we predict delayed perforation? Well, there is a very, very easy tool to predict this, and actually what we say is type 0 and type 1 should not be closed with clips. Type 1 shows actually the muscularis propria fibers. However, you don't see any defect within the muscularis propria. In type 2, it's the submucosal plane is really not clearly visible, so you may have done some snare tip soft coagulation, you may have burned quite deep, but you just can't see either the muscle or a nice blue defect. And type 3 is where you actually see a target sign. You can then in the resection specimen also see the mirror target sign. And then type 4 is a full perforation. So we say type 2, 3, and 4 should, and obviously type 5 should definitely be, type 5 is when there's also fecal soiling, should definitely be closed with clips, fully closed. So this is a nice example of a type 0. There's a bland defect, there's maybe some yellow from the submucosal fat, but that's it. And then type 1, as I said, you can nicely see the fibers of the muscularis propria without any damage to it. Here there is examples of type 2. As we said, we're not really sure here what happens. We have actually had to burn a little bit and here even more. So we decided to close this. This is on the left-hand side. This is a target sign I was talking about. You can read all about this in the article that is it is referred to, as you can see at the bottom of the slide. And actually on the resection specimen, you will see the same circular white ring, which is actually muscularis propria. And then on the right-hand side, this is something you rather don't see a full perforation, but clean. You can see probably serosal fat in there. And so as I said, all the DMI type 2 to 4 we should clip, and that way we can prevent delayed perforation.
So can we show the slides for the presentation? Maybe we can see them on the laptop. Yeah, so this is just a quick thing about the margin. It also involves a defect we talked with Michael in the live case. If you didn't see it, there's a great demonstration and discussion about how to do the margin ablation and the width of it and everything in one of the live cases we did earlier, I think in the large polyp section. You should go back and have a look at it. We know recurrence after EMR is a problem. Where does that come from? The margin. So there's two titles this talk could be. It could either be margin or mucosa. And I think that we've already talked about submucosa, we've already talked about the muscularis. The other thing you should be looking for is the mucosa. I mean, let's just ask the panel. I don't know whether you've seen this study. You almost certainly have. Everyone in this this panel is an expert in endoscopic resection. But can you believe this? I mean, let's just ask everyone. Everyone answer, please. John, do you believe this?
So I believe the effect. I have had this conversation with Mike several times. As he mentioned it, as time has gone on, I think our resectional technique has got better. Our interrogation techniques have improved. Our optics have improved. And therefore, the ability to detect residual lesions, I think, has improved. And therefore, the potential for recurrence, I think, would have gone down. But I don't think would have gone down by this magnitude.
So how have we got a 5-6 centre study, international, not just Australia, published in gastroenterology with a rate of 1.4% recurrence at first surveillance? Dominic, you got a view on that?
Yeah, these results are excellent, are amazing. So I hope we can reproduce them.
Well, that's the key point, isn't it? Can we reproduce them in the practice of everyone else out there doing endoscopy? And of course, you have to have a significant amount of expertise or have to do this, no? Do it properly, do it on large lesions, do it on massive defects, do it completely.
Yeah, absolutely. Well, and the data is what it is. I mean, you cannot argue with them, right? That's why we do science. It's not a matter of religion or belief. I think it's what it's written out there.
It seems religion or belief when you look at 1.4%.
Okay, I have no disclosures. What are the key questions? So first of all, if we decide we want to do EMR or ESD, this is particular about EMR, which defect features are there to be distinguished? We want to know, can we predict bleeding from this and can we prevent it from this? Can we predict perforation, preferably delayed perforation, and can we prevent it? So what are the defect features? Well, we've summarized them here. On the left-hand side, you see there is submucosal fibrosis in the middle here. My pointer is showing to you. And this is often due, for example, to a prior resection attempt or biopsies, or sometimes even when the lesion's very floppy and prolapses back and forth.